Now, our first speaker of the afternoon session is the Clinical Director for the lab in Beaumont Hospital and the Hermitage Medical Clinic, is an Honorary Associate Clinical Professor at the Royal College of Surgeons. He's the Chair of the Lymphoma and Haematology Group at Cancer Trials Ireland and the National Principal Investigator in Ireland for the CLL-13 study. He is the leading CLL expert. His particular areas of interest include P53 deletion and Richter transformation, myelodysplasia and thrombocytopenia. Richter transformation. No, I'm going to start again. Richter transformation, myelodysplasia and immune thrombocytopenia. Thank you. It's so much easier introducing politicians, I have to say, than medical experts. Minister for that. Anyway, look, he is a world-class expert in his field. That's all I really need to say. By the way, I should say at the outset, he's also in huge demand. If his buzzer goes off or his beeper goes off, he is going to have to run out of the room, and I think we can all understand the reasons for that, and none of us will complain if that is the case. But in the meantime, please give a warm welcome to Professor Patrick Thornton.
Thanks for that introduction. It's good when you get to my age that you collect titles instead of illnesses or complaints. Thanks very much. You're very kind. I'm delighted to be back here again. CLL is my major interest and was the subject of research I did when I was a younger man. And I'm delighted to be in the position that CLL is made so much headway with regards therapeutics. It's become a very interesting disease, and what I plan to do over the next sort of 45 minutes is take you on the sort of journey that I have lived through from a sort of hematology specialist registrar, a research fellow, and a consultant, and sort of witness these changes. And I've kind of put the dinosaur there to sort of represent chemotherapy, because I think we're coming to an era now where we may be able to do away with chemotherapy for CLL. And what I want to do is the first half is to take you through how we've progressed in how we treated CLL and how we investigated. Apologies, a lot of the slides are fairly medical, but I mean, I will talk you through them, and I think most of you are probably well versed in interpreting these slides if you've come to many of these venues before. So I've given the title The National History of CLL, and is this the end of chemotherapy? And we can decide when the lecture's finished whether you feel that it is or not. So CLL is as you know, is the commonest leukemia in the Western world. What makes it interesting is that it's what's called, has a heterogeneous natural history. So I mean, some people do extremely well and need only surveillance. Some people are less fortunate, and it does threaten their life and their longevity. And the top picture is the bone marrow of somebody with CLL. Your bone marrow, once you reach the age of 50, I mean, it normally 50% of it's full of fat cells, but you can see this bone marrow has been overwhelmed by a kind of monomorphic population of the leukemia. The next slide, the next slide is what CLL looks like in the blood, these sort of lymphocyte cells. And CLL can affect the bone marrow and also increase your lymph nodes, can be seen in your neck, under the arms, and the groin, and enlarge the spleen. And the tumor bulk tends to be associated with greater genetic risks to the chromosomes of the leukemia and a greater genetic complexity as the disease progresses. And at the very end of the spectrum is a condition called monoclonal B lymphocytosis, where somebody has a white cell count, a lymphocyte count of less than 5 in their peripheral blood. They are clonal and they have the same immunological fingerprint as CLL, and this is a commoner condition in people who have relatives of CLL, but the majority of these individuals will not progress to CLL and only need surveillance. Those that have a lymphocyte count over 5, what's called a stage A CLL, and many of them won't progress. They may have small lymph nodes in 1 or 2 areas, but have reasonable hemoglobin and platelets. And then CLL progresses, and we can talk about what that progression is that may require treatment. Some people are unfortunate enough that the treatment doesn't work, That's called refractory CLL. And then around 10% of people can develop a transformation of their CLL into something which resembles more like a high-grade lymphoma, and certainly is a difficult condition to treat. And there isn't even a recognized gold standard. And so that is, even today, unfortunately, a great threat, and certainly it can be fatal in many individuals. And this progression of CLL normally goes along with progression over prognostic markers. And sometimes you can collect these poor prognostic markers as your disease progresses. You may or may not, but this is associated with more aggressive and more refractory disease. And this is kind of called clonal instability, or the genetic instability, which we see in all cancers. And when we're talking about these markers, if I took cells from your cheek and looked at the chromosomes, they're the chromosomes you're born with. But if we look at the chromosomes of the leukemia, they have different abnormalities, and they are the chromosomes of the leukemia, which leads to its instability and its progression. And I'm just going to show you very quickly a few survival curves. And what that means is 100% of people are still alive at 0. And as the years progress, the patients die with time. And the dotted line is what's called age-matched control. So these are people who don't have CLL, and the black line is those that do. And so for a proportion of people that have good prognostic markers, they're stage 0, they have a mutation of their immunoglobulin gene, the CLL has no impact on their overall survival, and many of these don't need treated. And this was an opinion of CLL, which still exists today, but it's important to realize that it's important to realize two things. One, this population does exist, but unfortunately this is only the minority of patients. So doctors, hematologists and oncologists shouldn't become complacent of CLL, that it's a benign disease that they can ignore, because if we look at people who have an unmutated immunoglobulin gene, they do die of their CLL, as you can see, and overall, the younger you are, the greater this threat is to your life. And overall, even the older patients, CLL does kill people, without a doubt, as you can see from these graphs. But as I said at the beginning, there are certain things that we can do to determine who are the population of people who only need to see their doctor once a year, versus those people who will need more frequent observation, and those people who may require treatment, and what that treatment should be. And around the turn of the millennium, they looked into the chromosome abnormalities of the leukemia. There are a few of them. And as you can see, the dark line where all those patients have succumbed to their disease at around 80 months are those with a P53 deletion, which is contained on the short arm, or the P arm, of chromosome 17. And the people who do well, who are at the top, who probably have a similar life expectancy to people who don't have CLL, have a 13q deletion. And the other chromosomes are something in between. The other major prognostic marker that I've already alluded to is what's called a mutation or unmutation of your immunoglobulin gene. Now, what that means is our immune system, we're born with genes which instruct our body to make antibody to antigen, and antigens are contained on infection, germs, viruses, etc. To increase the diversity of our response to what's called antigenic stimuli, which in general is infection, etc., we can mutate that gene to give us a greater diversity of the immunoglobulin gene. So it's a more mature B cell, whereas the unmutated is sort of what's called similar to germline, and it's the B cell that you were kind of born with. So it's a more active B cell, a more immature, naive B cell, and those with an unmutation tend to have a more reactive CLL, which is more likely to require treatment. And this kind of splits up the prognostic markers to good prognosis versus bad prognosis. And so they are part of the markers that we would consider doing to give people an idea of what type of CLL they have, whether it's going to require treatment or may not, or may just require surveillance. And over the years, we've learned an awful lot of CLL, especially from the turn of the century, and there's been a huge morass of stuff that we know about CLL and how it interacts with the bone marrow and the microenvironment. And fortunately, that has gone along with an increase in the knowledge of the disease behavior. It's gone along with an increase of the knowledge in how we treat the disease, which I'll talk more about as we go on. So just to repeat to you, the heterogeneity or variability of CLL a quarter of patients will never require treatment and will have a normal life expectancy and just need surveillance blood count. It's important to realize that almost half the patients are over 75, so that will have an impact on what treatment we use to treat this leukemia, because when you're dealing with any treatment, the things you have to bear in mind are a triangle of performance status, efficacy, and toxicity. And what that means is, are you fit enough for the treatment? Does the treatment work? And are you going to survive the treatment? Or is it going to make you more sick than the disease itself? So it's important to realize that the majority of patients, and thankfully in Ireland, as we get older, we also get fitter, but that does limit the treatments that may be available to them because of their age. And even now, or perhaps no longer, you can tell me what you think when the lecture is over, but it's considered that the only prognostic marker that really influences your treatment is a deletion of P53 on the short arm of chromosome 17. So there are international agreed indications for treatment, and anybody who's ever seen me will be tired hearing this from me, but I am very pedantic about it because hematologists tend to be laboratorians. They tend to like science fiction, Star Trek, and they tend to like definite blacks and whites. And so we like that there is a certain degree of objectivity in the decision which you make to give someone treatment. There aren't any treatments without side effects, even the modern ones. And the older you get, the more illnesses you can collect and the more symptoms you can also collect. And it's very important to realize that not everyone feels perfect, but to understand that if someone does feel unwell, that the reason they're feeling unwell is the CLL and not something else. Because it can be a disease that can just be watched. There's no benefit in treating disease that doesn't need treated. So there's this long list of reasons of why we treat it, and I'm not going to go through it, I'm just to aware that it's there. But I can summarize that before treatment, what I consider is the 4 Ps. And the first P is the disease progressing? Is it getting worse? Is the person developing a very rapidly and rising white count, increasing lymph nodes, losing weight, etc.? Is there evidence of progression? Is there what's called peripheral cytopenias? And what that means is your bone marrow will make 3 cell lines: the hemoglobin, which carries oxygen around the body, the platelets, which stop you bleeding if you cut yourself, and the white cells, which contain lymphocytes, which are your leukemia, but also neutrophils, which help fight infection. So peripheral cytopenias means these are reduced. In other words, you could be anemic, and when you finally got it on the 3rd attempt, thrombocytopenia, which means you've got low platelets, or even neutropenia. Now, the reason that would require treatment in CLL is if the bone marrow, like you saw on the very first picture, is completely wiped out by the CLL, and your bone marrow can't function properly. It's called marrow failure. It's certainly a reason to treat it. But there are other reasons for having low counts in CLL, and these can be autoimmune, such as immune thrombocytopenia, hemolytic anemia, where you're destroying your red cells, or immune neutropenia. And when you have CLL, your immune system, unfortunately, becomes slightly what's called anergic or slightly incompetent, and so your ability for your immune system to control its own response to stuff becomes impaired. And that is not just an increase in infection, but it's also an increase in its regulation. So your immune system can make cells that it shouldn't, which will destroy your platelets or destroy your red cells, and these are called autoimmune cytopenias. And it's important to know why someone's anemic. With that, is it immune, is it CLL, or is it just simply they need iron, or they need B12, or they need folate? For example, colonic cancer is a lot more common than CLL, and the older we get, the more common it is. So it's important if someone's anemic to make sure that they don't just have low iron because they're bleeding from somewhere. And again, as I said at the beginning, not to blame CLL for every complaint. And that's important to have that knowledge. Performance status, as I've said, will determine what treatment you're able to give. You may have the best treatment in the world, but there's no point in giving it to you if it kills your patient. Yeah. So and that will come through in the rest of this talk. And performance status certainly has driven the way CLL treatment has gone. Because as will become apparent, there are some very good treatments in CLL which you can't give to the majority of people who have CLL. And again, the P53 determines what treatment you get, and I will explain why. So, just a reminder again, a quarter of people will never need treatment, and they are likely to be female, they're likely to have a 13q deletion, and they're likely to have a mutation of the immunoglobulin gene. So these are what is known as the good prognostic markers, which generally translate as not needing treatment and good longevity. Peripheral cytopenias that I've alluded to, there are many reasons of why they can happen. And before treating someone, we need to know why you have these peripheral cytopenias. And what about P53? And I begin to sound like I'm harping on a bit too much about it, but P53 in any cancer, and CLL is not unique, will worsen the prognosis. This is a protein which is 53 kilodaltons, that's the weight of it, which is why it's called P53. It's contained on the short arm of chromosome 17, and when you damage cells, either by radiotherapy or by chemotherapy or by cancer itself, then this protein is recruited to kill the cell off. And when a cell dies, that's called apoptosis, that's called cell death. Without that protein, the chemotherapy will only get so far, and the cell won't die off, and then it develops either resistance, early relapse to chemotherapy. So that's why, if you remember the very first survival curve that I showed you, that's why P53 can be lethal and certainly bad in anyone that has it in CLL and indeed any cancer. Now, how do we determine whether someone has this abnormality or not? We know that it's contained on the short arm of chromosome 17. So when we're looking at our chromosomes, the problem with CLL is the cells don't divide that quickly. So we have to insert little probes into the cell to see whether the CLL, the disease is, the genetic material is deleted or missing. If you look on that little picture on the right, I don't know how well it comes out, you'll see there's 2 green dots in all of the cells. And they are probes for what's called the centromere, or the center of your chromosome 17. And you can barely see a tiny, tiny red dot because it's a tiny little probe. And that probe is for the P53. And you'll see that a majority of those cells, and these were cells in a UK CLL4 trial done in the UK, and where this was screened for all patients. And these are the days when we still give chemotherapy to people who had P53 deletion. But you'll see a proportion of those individuals are missing 1 red dot, which means they're missing the P53, which means they've got a P53 deletion. The other thing you may hear is something called a P53 mutation. Now, they know it, which means that the genetic material is confused or mixed up, and so the protein is not manufactured, and so therefore your P53 doesn't work, and therefore you'll do badly. They usually occur together. This is my own handiwork, but when we did the sequencing of the gene, so we're looking at the actual genetic material, your genetic DNA code that writes the P53, we pick up the mutations here, which you see these little black arrows. Now, back then, that sequencing was done on a gel, which would have been the size of that window in a room this size, and it would have taken about 3 days. Yeah, and that was called Sanger sequencing, where you read the DNA. So it was, not amenable to everywhere. That was done in what's called the Bob Champion laboratories. You may remember he was a jockey and he sponsored these labs in Marsden. But nowadays, P53 can be done with something called next generation sequencing, which is a lot quicker, and the machine which does it is about the size of this podium. Not only that, it can be done at a much deeper level where you can pick up smaller and smaller probes. So that is kind of the way forward. And in even the fish, which you see there, fluorescent in situ hybridization, again, it's even quicker and more sensitive to that. So that's probably the way forward in how we detect P53 in the future. How is it important? If you look at any trial where chemotherapy was used, if you have a P53 deletion, you do worse. And so these days, it's generally accepted in most countries that treat CLL, and certainly all of them in Europe, that if you have a P53 deletion, you should not have chemotherapy, ever. You should have something else. That's just a reminder of the slide I showed you. And why am I saying that? Because Although we have very good combination chemotherapy and what's called fludarabine, cyclophosphamide, and rituximab, although it improves almost everyone else, the P53 makes no difference. So with the improvement in chemotherapy over the years has improved how we respond with the other bad prognostic markers. It has done pretty much zero in the improvement in survival of people with P53 deletion. So therefore, if you have a P53 deletion, you shouldn't get chemotherapy at all, ever. Okay, so how about the people who don't have P53, and how about chemotherapy? And I just showed you this graph on FCR, and it looks absolutely fantastic, and people do very well. And there was a poster at ASH now 7 years ago where they found that a cohort of patients in the MD Andersons treated by FCR chemotherapy still have no evidence of CLL 10 years out, so they're probably cured. That's brilliant. But if you look at the paper, you'll find that they were only really able to finish it in about a quarter of the patients. And it is only about a quarter of the patients that actually got the long-term remission, and only about a quarter of CLL patients would be fit enough for FCR in the first place. So a quarter of a quarter of a quarter. Okay? And that's where we get where toxicity affects what you can give. So you may have a very good treatment, but it may not be available to everyone. One way around that was they said, well, maybe we'll shorten the amount of FCR that we give people. Only about half people got 4 in the courses instead of 6. And so this Australian group looked at people who got 4 cycles of FCR and looked how well they'd done and see if we could abbreviate the FCR. And one way of determining how well you're doing in CLL is to measure the amount you've got left in your bone marrow. That's called minimal residual disease. There's various ways of doing that, but people who were what's called MRD negative, which means they'd less than 1 in 10 or even 100,000 CLL cells in their bone marrow, were called MRD negative. They stopped the treatment. They thought they'd done well enough, and they did just as well as people who had 6 cycles. Again, good. It's a way of reducing the toxicity of the chemotherapy by saying we can stop early because you've done well enough. And about a third of, and this is about 300 patients who got CLL, so these are fit patients, but even at that, as good as it is, less than a third are still in a long-term remission, okay? Then they looked at detoxifying CLL and making the chemotherapy more appropriate to the age group and performance status of the people who needed treatment. And they brought out this drug called bendamustine, and they compared it with FCR, and this is in the German CLL-10 trial, and they found that if you're over 65, that you did as well with bendamustine as you would fludarabine, and then that became the sort of treatment for older, slightly fitter patients. And then they took that one step further again, and then they looked at a less toxic drug called chlorambucil, and all of these treatment regimens are what's called chemo immunotherapy. And what that means is you have chemotherapy and you have a targeted monoclonal antibody. And your CLL cells, if you have them, express something called CD20. It's on the cell surface. And you can have an antibody to the CD20, and we have one called rituximab, there's one called obinutuzumab, which is slightly more powerful, and it's a sort of more targeted therapy with less toxicities than chemo. And so when you combine that with chemo, you get a better result. And so what they did as the chemo immunotherapy regimens progressed, they lessened the chemo and made the antibody better. And that's with this CLL-11 trial, where they just used chlorambucil, which is a fairly low toxicity chemo with a better antibody called obinutuzumab, and found that people did pretty well. And if you look at bendamustine and rituximab, remember, which in the older people is almost as good as FCR, you can see that you got a fairly reasonable overall response rate. Now, yes, it's not as good, but if you look at the population, they were older, 74. A SEER score stands for Cumulative Illness Rating Score. So if you have high blood pressure and you have treatment for it, you get a 2. If you've got ischemic heart disease and you've got a treatment for it, you get a 4. If you've got thyroid disease, you get a 6. You get the picture. So the SEER score, most of the people in the chlorambucil, the obinutuzumab trial was 8. So they had either 4 illnesses that were medicated for or 3 that they were medicated for twice. So more representative of what they call real world population. And they did pretty well. Overall response rate 77. But if you look at the amount of severe neutropenia, it's less than 10% versus over a quarter of the people who got the bendamustine. So that is sort of now then was advised as the chemo immunotherapy regimen for older people, and you could argue that older people or less fit people represents the majority of CLL treatment. So that's where we got to with chemo immunotherapy. Perhaps we got to the stage where we've got an overall response rate of 77% in the majority of older, less fit patients, which represent the majority of CLL patients. So, but what are our gaps? We've no real treatment for P53. And, well, there's obviously room to improve in 77, as good as it sounds to you, because that's 77%. In 4 years, most of them, their CLL will have come back again. So there's obviously room for improvement. Now, before I go on to the sort of second half of the sort of changes in treatment, just to remind you, some patients shouldn't have treatment at all. Some patients should not have chemotherapy, and maybe by the end of this, we should say nobody should have chemotherapy. But some patients definitely shouldn't, and they're the ones with a P53 deletion. And one thing which I can say with absolute certainty, and I'll prove it to you in the next slides, is that patients should not have chemotherapy twice. Okay? And how do we identify who these patients are? So, who shouldn't have chemotherapy? And it's now in what's called the British Committee for Standards and Hematology Guidelines that to test for P53, and if you have it, you should not have chemotherapy, because we have an alternative treatment which works and chemotherapy doesn't. So the P53 should be tested for, but it should be tested for before treatment and at every treatment. And the reason I say that is because you may not have P53 when your CLL requires treatment the first time. But as in many people, unfortunately, it comes back in relapse, you can then acquire it. And if you look at this graph, this is a mirror of the progression tree that I showed you in about the third slide. And the more your CLL progresses and the more unstable it gets, the more likelihood you have of acquiring this P53 abnormality. So with every time a decision is made that you need your CLL to be treated, you should test the P53. So having it negative at diagnosis does not mean that it's negative at time of treatment, at time of second treatment, at time of third treatment. So it should be tested at every line of treatment. The ways of doing it is, as I've showed you in a little diagram, you can do it by fluorescent in situ hybridization. But nowadays they do it by something called next generation sequencing. And there's a whole committee in Europe which is looking at next generation sequencing all over Europe, along with other genes, but importantly P53. And we collaborate with the UK Reference Centre in Belfast with a guy called Mark Catherwood, and we test this along with some other genes in all our CLL patients who are requiring treatment. Now, so if we're going to do away with chemotherapy, what other ways can we use to kill CLL cells? Now, we know quite a bit about the various conversations going on with CLL and the other cells in your body and bone marrow, and that slide's not, I'm not going to explain that slide, it's just to demonstrate that. But essentially you can block interactions with T cells, you can block what's called the B cell receptor, and you can block something called BCL2. Don't worry, I'll explain to you what that means in a minute. Now, all of us can get infection. Think about what happens to you when you get a viral infection, okay? Your lymphocyte count will go up, and you might get swollen glands. If any of you ever had even glandular fever or any significant viral infection, then what happens, the infection goes away, and the white cell count goes down again, and your lymph nodes disappear. So how does that happen? Well, our body, when we get infection, the B cell, which is all B lymphocytes, is stimulated by something called the B cell receptor. So that's the on switch. So that makes the cells proliferate. But the cells are all programmed to die off. Now, to keep them alive, there's something called BCL2, which is something called blocks apoptosis. So that's the off switch. So when we have an infection, the on switch is on, and the off switch is off. You with me? Yeah? So the off switch is BCL2, and the on switch is the B cell receptor. So the new therapies that we use now to treat CLL without chemotherapy are to block the B cell receptor, in other words, to switch off the on switch, or to block BCL2, which is to switch on the off switch. You got that? Yeah. Now, so the B cell receptor has various downstream chemicals. One's called Bruton's kinase, discovered by this guy called General Bruton in America. Another one's called P53 kinase, and they're the downstream activation markers which makes your cell divide and move around and kind of be nasty to you. Now, if we block that, and one of the drugs to do that is something called ibrutinib, then your CLL gets switched off. And this is one of the survival curves in people who had already relapsed after chemotherapy, treated with ibrutinib in the black line versus treatment naive. So you can see an extremely good response rate, and these included people with the P53 deletion. This is a CT scan of the very first person ever to get ibrutinib for CLL in Europe. She was an 82-year-old woman from Griffith Avenue. And as you can see, I'm not imagining you interpret CT scans, but you can see that there's a lot less round things in there, which are the lymph nodes, after the treatment than there was before. And she lived for 4 years after having 4 or 5 rounds of chemotherapy and died of old age, really, with ibrutinib. Now, the point is, she had been multi-treated with chemotherapy. Chemotherapy is no longer an option for her, but she had 4 years of ibrutinib, celebrated wedding anniversaries, etc., and got considerably more life out of it because there was no real toxicities for her. Yeah, this is another B-cell receptor inhibitor called idelalisib. Again, similar response rate to ibrutinib. It's kind of slightly less favourite than ibrutinib because it has slightly more side effects. It can cause inflammation in the gut and the lungs, so it's probably not used as much as ibrutinib is these days because more of the side effects. But another good drug, and it can be considered in, where there are indications where you can't use ibrutinib. Now, what I didn't talk about, and it's getting more difficult for me to try and be comprehensive about CLL, because I do understand that some people in the audience may have this disease and may be very young or fit. And traditionally, a bone marrow transplant was considered in the treatment algorithm for CLL who didn't respond to chemotherapy, who had a P53 deletion. And it's difficult now to decide where to put this in, which is why I've sort of clumsily thrown it in the middle. But it's important to realize is these are all pretty top of the range transplant centers in Europe and America. And if you look, they all got sort of an average of 100 or so patients. They're all refractory to chemotherapy. Some of them may have a P53 deletion. But look, relapse at 4 years, almost half of all of them. And extensive GVHD. Now, I don't know whether there's any transplant people in the audience, but having GVHD is no walk in the park. It's like having really bad psoriasis. You might have chronic diarrhea, or you might have the equivalent of an emphysema because of GV lung. So it's not an easy thing. And what you've done is replace one chronic condition, the CLL, with another one called GVHD. And all the people who had transplants, half of them get GVHD, and less than half of them are cured, and the other half relapse after 4 years. So it may be the only option for someone previously a transplant, but it's certainly not as good as you'd see for AML or CML or other conditions that we use it for. And again, not an option for the majority of patients because of your overall background fitness. So the algorithm for having a transplant in CLL has pretty much changed, that it used to be for fit chemo-refractory people with P53 deletion, and it's now really only used in fit people where really even the novel agents have failed, such as ibrutinib or idelalisib. Now, what do we do when the disease comes back? So say you have ibrutinib frontline for your P53 deletion and your disease comes back again. What do? Well, we have the other option where we can we can turn on the off switch, and that's called a BCL2 inhibitor. That drug's called venetoclax. Okay, so now we still don't need to use chemotherapy for relapse, and this drug has been used in clinical trials where they had relapsed patients, and this is why I say you should never have chemotherapy twice, because they looked at it, bendamustine rituximab versus the venetoclax, and the green line is the venetoclax and the blue line is the bendamustine. Now, most people will get about 2 years out of bendamustine rituximab in relapse. You can see there in the graph. And it takes 6 months to give it. So you get 6 months of treatment for 18 months of remission, your CLL comes back anyway. Versus venetoclax, we can see they do twice, 3 times as better. So this study is called the Murano study, is now the recommendations in Europe for hematology that if you have whatever you get frontline, if your CLL comes back, chemotherapy is not the option for second line. So, just to summarize what I'm trying to say is, if you have a P53 deletion, you should never get chemotherapy ever. Get ibrutinib or a new drug. If you don't have a P53 deletion, you get chemotherapy first time. When the disease comes back, you shouldn't have chemotherapy again. You should get ibrutinib or venetoclax. And if you have ibrutinib and your disease comes back, you still have venetoclax. So we're not using chemotherapy in any of these situations other than front line. Now, I'm anticipating a thought which is growing in all of your brains. If these treatments are so good, why the hell can't we just give them to everyone front line? We do that in myeloma, we do that in acute leukemia. Why are the CLL the second-class citizens? Okay, that's a reasonable question. What we did, we agree, the sort of hematology community agrees that we should look at bringing these treatments into the front line setting. And we did that in a trial. Before I get to that, that has been looked at in various trials, mostly in America and around Europe. And these trials were presented at ASH, which was 6 months ago. And I just briefly, am I out of time? No. Yeah, I shall briefly just summarize them for you. So, first chemotherapy I talked to you about, FCR. We all thought it was brilliant, but not appropriate for everybody. So they compared FCR versus ibrutinib and rituximab. Randomization, FCR fit people, ibrutinib and rituximab versus FC rituximab. Ibrutinib's better. Okay. So, what about bendamustine? Sure, I said that was fantastic. Bendamustine, rituximab versus ibrutinib and rituximab. Randomization, ibrutinib alone, ibrutinib, rituximab, bendamustine, rituximab. Ibrutinib's better. And it doesn't really matter whether you give rituximab or not, ibrutinib's better. Okay, but, bendamustine, fludarabine, cyclophosphamide, they're fairly toxic, we can't give that to everyone. You said that, most people should get carambacell and ibinituzumab. It represents the bulk of CLL patients, the older patients. 77% response rate. Sure, that's brilliant. What more do you want? It's low toxicity. 6% severe neutropenia. Sure, it's great. So, that bendamustine, FCR stuff, you're not representing the majority of the CLL cohort. Okay, well, I have that for you. So we have, and just because I've been talking a bit, so we have that as well. We have chlorambucil and obinutuzumab versus ibrutinib. Obinutuzumab, ibrutinib's better. Ibrutinib's a lot better. And when you look at the safety, ibrutinib's even lower side effects than chlorambucil and obinutuzumab. And chlorambucil and obinutuzumab, they talk about minimal residual disease. You can also get that with the ibrutinib monoclonal antibody combination as well. So we now have trials done and completed and published in ASH that show that the novel agents are better than chemotherapy. We know they're better second line, we know they're better in P53, now we know they're better in everything. Now, the only way to get novel agents frontline in Ireland currently is to enter a trial, which has been open and was open until August. And this trial looks at chemotherapy in fit patients versus ibrutinib and venetoclax and venetoclax in the combinations. And the combination is really that makes the most sense. Not everyone may need it, but the combination is, as I've said to you, ibrutinib switches off the on switch, and venetoclax switches on the off switch. So if we can combine the two, then we'll have, a very effective way of managing your CLL. And if you throw an antibody in, which again is low toxicity, you may be even able to cure CLL in a number of individuals. So this is, again, back to our little scales of, pro-life and anti-death in our cancer cells. And if we affect both those pathways, we'll get effective cell killing for our CLL. Okay, and we did that in a randomised trial, which we're running in a number of centres in Ireland, Beaumont and James's, and the Mater in Dublin, Galway, and Cork, and Waterford. And essentially, only 1 in 4 people got chemotherapy, and the remaining 3/4 got venetoclax plus an antibody, or venetoclax plus ibrutinib, or venetoclax and an antibody plus ibrutinib. And we're doing pretty well in recruiting that in that trial. When we took it on, we said that Ireland would put in 30 people, and we've already put in 35, and we've got 3 more months to go. So Ireland's recruiting very well in it. People are doing very well in it. What I can tell you is that although this trial hasn't finished yet, and although the results aren't published yet, there is a trial of ibrutinib venetoclax combination which will be presented at a conference soon, probably EHR IWCLL, which shows that the combination of ibrutinib and venetoclax, including P53 patients, has a overall response rate of 83%, which is better than FCR, and that includes the P53 population. So we know from some trials already completed that ibrutinib venetoclax combination is excellent and not very toxic. So I don't know how much time I've taken to do all that. 5 minutes left. Perfect. Because I'm finished now. Yeah. So when I started this talk off, I tried to sell you chemo-free treatment for CLL. Is chemotherapy the dinosaur? Okay. So what's the next step? And in about a year's time, or maybe a year and a half, we'll be opening another trial called CLL17. Now, I've signed what's called a non-disclosure agreement, so I can't tell you exactly what the arms are, but I'm sure you know. What I can tell you is frontline, all patients, P53 included, all ages, all level of fitness. All CLL patients go into the one trial, and there's no chemotherapy in it. That's called CLL17, and that should open Q3 2020. And so we put 35 in CLL13. That was sort of fit patients who didn't have a P53 deletion. My guess is we could put 100 in that. So I think, probably maybe not the 2020 CLL Ireland, but certainly the 2022 or whatever CLL Ireland, people won't be getting chemo. People probably won't be getting chemotherapy anymore. I remember about 3 or 4 years ago, I was doing one of these interviews at ASH, and it was John Gribben was sort of interviewing us, and first question he says, so Patrick, do you think chemotherapy is the end of chemotherapy? This was after what's called the Resonate-2 study. It was the ibrutinib study with that lady whose CT scan I showed you, and she says, well, Patrick, do you think this is the end of chemotherapy from CLL? And says, oh yes, absolutely. And the other 3 guys in the panel, I just heard them going, but I think, maybe I was a bit previous, but I do think my answer was right. Anyway, thanks very much.
Okay, absolutely fascinating. Thank you so much, Professor Thornton. Professor Thornton has very kindly agreed to stay back for a little while more. We're not sure we're going to have him at the end for our Q&A session, so we thought we'd pin him down now. We've handcuffed him to the chair for a few moments to get some of your questions. So if you've got questions, we have a mic here. There's a gentleman in the middle there with a question straight away. Thank you, sir. And just raise your hand if you have a question, and we'll come to you next.
You're very fortunate, and congratulations.
Anybody else with a question? Yeah, gentleman here at the front. Oh, sorry. Yeah, sorry. I'm just going to record the answer to this. That's my 8 o'clock on Tuesday morning, Monday morning taken care of.
In answer to your first question, which is an easy one, only if you require a blood transfusion, your blood will be tissue type, but your rhesus type has no influence on your prognosis or your treatment. The second question is, there are many excellent centres in Ireland that treat CLL, and as you can see, all of the centres which signed up to CLL 13 recruited similar amounts. So I think the standard is good no matter where you go. But you should ask Rachel Fox that question, and she might be able to give you a less PC answer.
It's a very political answer, Patrick. Congratulations. Gentleman here at the front has a question as well. And just anyone else, put up your hand, and we'll come to you.
Well, in CLL 13, I think we're very fortunate to be included in the German CLL study group. Now I say German CLL group, but that also now includes Israel and Switzerland and the Netherlands. So most of industrialized Europe and the UK were doing something very similar. And in Germany, a lot of these drugs are reimbursed as soon as they get licensed. So they're very progressive trials, and there tends to be no need for a placebo. And so all of the arms in CLL 13 were very effective treatments, including the one you had, FCR. And those trials began, and you're talking 1,000 patients throughout Europe, which recruited very quickly. And those trials began, and the other trials which began in America, which have now come through, you could say, well, they've already answered the question. But you can say that trial had a good design because the two things, what you would call experimental arms was 3/4 of the patients. Now that is a huge leap of faith to do that, to have 3/4 of the patients not have what's called your gold standard treatment, which is proven for 10 years, including yourself, including the FCR. So that was a huge leap of faith to have the majority of patients in your experimental arm, but there was so much faith and belief in the science of these drugs that was the right thing to do, and that has been proven the right thing to do in the other trials which were presented at ASH. The next trial, CLL 17, will all have, I'm not allowed to say, but a certain backbone, which is very effective. So all the treatments, nobody, all the treatments will be extremely effective. They will all have a novel agent in it. And either single or in combination. So all of the treatments are good. If you want me to say to you what we should do in the absolute future when we have the answers to everything is, not everyone will need a triplet, which is an antibody and venetoclax and ibrutinib. Some people might be fine on just one drug. And there's other debates which will come forward. Can we stop treatment? Ibrutinib, do you have to continue it forever? We do know there's heterogeneity, and there's about 3 different types of CLL patients. That person who will never need treatment at all, that person who will do reasonably well about treatment, and that patient who will relapse quite quickly. So I don't think everyone needs a triplet, but I still think we can continue, because you could say, well, is CLL 17 transfusion treatment? Everybody doesn't need to know what the P53 is, doesn't need to know what their NGS is, or what prognostic markers they have. I think we still do, because we can refine our treatments to give the triplets to the ones most at risk and save ibrutinib single agent for the people who are less at risk. But one thing I do believe is that chemotherapy is gone.
Okay,
you're happy with the answer. In answer to your question, no placebos in any of the trials for CLL in Europe.
Okay.
Maybe that's all I should have said, sorry.
No, it's a good answer. Where did I see a lady had her hand up there? Where was it? Sorry, there, in the middle. Sorry, excuse me.
Can I just say before I go to you for a question, we do have some questions on the slide that came from the audience initially, so we might try and get some of them are clinical questions.
Yeah, okay.
So.
Well, it shows that you're likely to be in one of the better prognostic groups. To answer that question comprehensively, it'd be useful to know whether you have a mutated or an unmutated immunoglobulin gene, which not everyone does, but can easily be done. I mean, they certainly do it in Beaumont, they do it in James's, and they probably do it in Galway as well. And that could give you a better idea. Now, one thing I would say is that the reasons for treating your CLL never change, whether it be front line, second line, relapse, and they never change. Why you need treated. The chromosomes don't impact on that. They only impact what treatment you give. So if you develop symptoms, hopefully you won't, you're less likely to with that genetic profile, but if you develop symptoms, if your disease needed treatment, those tests need done again, because the fact is you're P53 negative now doesn't mean you always won't be. I know you're P53 negative now because they would have done the full FISH panel, including P53. But if your condition changes, if you develop progression, hopefully you won't. Yeah.
Okay. There's a gentleman there at the back, that's at the pillar, and then we might get to one or two of the questions. Yeah. Just get to that gentleman first. Yeah, great, thanks.
And I just remind everybody as well, try
You're
not to
granted
make
that,
your questions too personal, as they probably can't be answered.
Yeah, that's a really good point. Just let's try and keep the questions general, because obviously it's very difficult for Patrick. He can't remotely diagnose. So we might just sort of keep it general, understandable that people have very specific questions, of course. Great question.
It's a very good question, and you could argue that the only reason that people don't get frontline ibrutinib venetoclax now is fiscal. But let me. The relapse argument is very easy to make. To give someone bendamustine rituximab for 6 months for just 18 months remission, and then they end up getting ibrutinib anyway, makes no sense. There are many conditions. The argument, the fiscal argument for ibrutinib is that you continue to take it forever. And so therefore it's a chronic increasing burden on the taxpayer to treat this condition. But it isn't significantly different from what we already pay for other conditions like myeloma and other conditions. And I'm not saying it's a cancer competition, but I know what the prices are, and they are similar to many other long-term maintenance treatments that we use. That's the first answer. So they are expensive, but similar to other anti-cancer treatments. I think the way forward perhaps is what's called a finite treatment, where you have treatment and it stops. That's probably going to be 2 or 3 years, and get in an MRD negative population. But all the arguments that are made, the reason that ibrutinib is licensed and the reason venetoclax is licensed and reimbursed is because these financial arguments were made to the HSE and were found to be prudent financial arguments, or the government would not have reimbursed them. I hope that answers your question.
Okay, Nick, you had a quick question you wanted to ask?
Yeah, it's just a very brief question.
Just wait for the mic, because there might be people in the end who can't hear. Yeah.
Prof, just a very brief question. Is exciting times. We're bringing these therapies further forward into frontline, and obviously with the treatments of a fixed duration, the fiscal arguments are going to be much stronger. With, I think there is ibrutinib, Veno, venetoclax, obinutuzumab over 1 year.
Yeah.
Fix coming in now for appraisal within the UK through NICE, and then we have other fixed 2 years already approved by NICE, which hopefully. So the question really coming there is, what are your thoughts with this new strategy about sequencing, where we look at figures, not the response figures are tremendous,
yes,
but on relapse or should eventually relapse, where do we go from there?
So the first thing when you're talking about sequencing or minimal residual disease monitoring, the reasons for treating CLL never change, whether it be frontline or relapse. So it's not, you're not talking about someone who's had a transplant, you're not talking about someone with AML or CML. So the reasons for treating somebody a second time are the same, the lymphocyte count, the lymph nodes. So you don't need MRD serial monitoring to look out for early relapse in the majority of patients. With regards sequencing, I think that what will probably be, you're asking me it's a crystal ball question, you'll admit that, but I think what inevitably we will do is we gather up the sequencing information, and we will have cohorts of patients who we know will only need ibrutinib. MRD negativity is less important, versus people who will likely develop a BTK mutation or a PI3 kinase delta mutation. And MRD negativity is much more important because your clone can't mutate if it isn't there. So I still think the NGS prognostic markers are important to determine the high-risk CLL individuals who they are, to try and achieve MRD negativity in them. The people who may have a mutated immunoglobulin gene or 13q and have low risk of acquiring BTK mutations, have more genomic stability versus genomic instability, are those where perhaps ibrutinib on its own is enough for them. So I still think it's important to gather that information. Does that answer your question?
We'll have time for one or two quick questions from the audience, but I would like, Patrick, maybe just a couple of questions. One, maybe the research into familial CLL. These are questions, Patrick, that were sent in to us earlier on.
Yes, I did it. So familial CLL is an entity where if you have any lymphoproliferative disorder in a first degree relative, whether it be lymphoma or myeloma, whatever, but it increases your risk of CLL. But remember, it's 1 in 20,000, 1 in 25,000, still a rare disease. So we don't introduce screening to family members. The interesting thing about CLL is that it does something called anticipation. So what that means is, you see it in Hodgkin's disease, that if you have CLL, if your father has CLL and you have CLL and he got it when he's 60, you'll get it when you're 50. And you see that in something called Huntington's chorea. So they looked for these repeats that you see in Huntington's chorea on genes, which get shorter with every generation. They didn't find them. And one of the things I did in the Marsden, we looked at the genes that we know happen in CLL, like 13q, P53, 17. There was another one called 6q, to see whether they were more common in CLL family members than non-family members, and didn't find them either. So there is a paper on it. My name's on it, but it exists, but we don't know the gene for it. So I don't know if the research is still ongoing, but we certainly did it at one stage. Yeah, but we don't screen family. Remember, I had a family that 3 of them had CLL, the other person had essential thrombocythemia, and the other person had a brain tumor, and that was their entire family. So we don't know what the gene is, but the majority of patients with CLL is what's called non-familial. But the familial versions do exist, but not common enough that you screen your family members. But it's important to tell your doctor. Yeah.
Age profile, how significant is that? Does CLL in younger patients progress faster, was a question we had.
Well, not that it progresses faster. The progression is determined to a certain extent by your immunoglobulin gene and what other genetic abnormalities you have. But if you saw the 4th slide I showed, the impact on life expectancy is worse if you're younger. If you looked at the graph, compared to age-matched controls, if you get CLL when you're younger, there's a much bigger difference in age-matched controls if you're under 55. Now, the thing about CLL prognosis is that everything you tell someone is already out of date. So hopefully, with all these novel agents, it won't matter at all, because hopefully we can be able to cure the disease.
Patrick, the various questions on eye problems, do you want to deal with that briefly as well?
It was listed in the scientific profile of ibrutinib, but I only ever saw it once. You know, it wasn't a major issue for me. You know, but if anyone else has different experience, but it was listed as one of the things you had to look for in the RESONATE trial. But I saw dry eyes in a couple of patients, but never anything called iritis or anything very serious. But we did have to have routine ophthalmology assessments of people on ibrutinib in the trial, but they're not in routine practice now. And it's not something I see. I see more arthralgia than eye problems.
Eye problem was a
Don't really see it. Don't really see it. No. Yeah.
Other side effects of treatments? Do you want to deal with that one as well? That was another question that came in, Patrick.
They're particular for each. If we look at ibrutinib, they talk about atrial fibrillation, high blood pressure, you get early diarrhea, and it increases the risk of bleeding. If someone's on ibrutinib, it's important that if they're having procedures done, that whoever's doing the procedure knows they're on it. Because it can increase your bleeding risk. So if you're having surgery or biopsies, you need to be off it for a few days. The atrial fibrillation is something which can happen when you've been on it for years. So if anyone develops palpitations or shortness of breath on ibrutinib, they should tell their doctor and have an ECG. Then the venetoclax, the main most important side effect of that is that it kills the CLL cells very, very quickly, and they die off very, very quickly and are flushed out through the kidneys. So when you're starting venetoclax, you have to start it at a lower dose and work up to it. That's called tumor lysis syndrome, and you have to prevent that by introducing the venetoclax over a 6-week period, which most people do. They're probably the biggies.
Okay. Anyone else want to ask a question? Brian, in the front here.
Yeah,
stick your hand up, by the way, if you do want to ask a question. We have time for one or two more. Yes. Yeah.
I know you've done some research on Richter's transformation. Have you ever seen anyone present with CLL or SLL and Richter's at the same time? Have you ever seen that, or is it always a late development?
If I saw someone who said they're Richter's transformation who never had treatment, I would ask for the histology to be reviewed. I did research on Richter's transformation, and we looked at Richter's transformation after fludarabine, and a certain amount of them were driven by what's called Epstein-Barr virus. And if someone has a solid organ transplant, then like a kidney transplant or lung transplant, they can get something called a post-transplant lymphoproliferative disorder. The Epstein-Barr virus drives this lymphoma. So we looked at Epstein-Barr virus in people after fludarabine and found a cohort of them had pretty much like a PTLD. And so you can find Epstein-Barr virus in certain Richter's transformations. You can find almost like Hodgkin's type transformations. And not all Richter's transformations are the same. Some of them do better, some of them do worse. As somebody who's had early CLL, who didn't have a P53 deletion, who had not had any treatment, who had a big lymph node that somebody thought was a Richter's transformation, who had never had treatment, I would definitely insist on that histology being reviewed, because I would doubt it. And someone very close to you went through that very same thing, geographically close to you.
Yes.
So, in short, to answer your question, personally, no. And I think I would definitely want that histology reviewed by an expert. Because your cells can be changed by a viral infection, even like herpes simplex infection stuff, and they'll settle down again. So I wouldn't leap at that at an early diagnosis.
Okay, 3 hands up, so can we keep going?
Are we okay?
Are you okay?
It's you.
Yeah, I'll try.
Okay, and then we go. And then
Yeah. Yes,
I need some adrenaline.
Yeah.
It's the same.
Okay, yes, sorry, your question?
No. The United States and Germany will reimburse a drug as soon as it has a license. And there's a process for a new drug coming online is that, first of all, the drug needs a license, and in America that's called the FDA, and in Europe that's called the EMEA. When a drug goes through usually what's called a phase 3 clinical trial in enough patients, it gets a license. They're usually called licensing studies. And when the drug is licensed, it means it can be prescribed. But as you know, these drugs are expensive. Ibrutinib is about $5,000 a month or something like that. And so, that would be beyond the pocket of most individuals in the population in Europe. So therefore, the drug goes through something called a reimbursement process, where the pharmaceutical companies and the HSA meet. The pharmaceutical companies say this drug is brilliant and here's what we have to prove it. And then the HSE decides whether they can afford to pay for it. And there's a bit of negotiation goes on, and that's called reimbursement. Now in Germany and in the States, if a drug has a license, it can be prescribed and is paid for by the state. That situation does not exist in Ireland. We're not too bad compared to most in Europe. Nick will probably be able to tell you the process through NICE and through England. It's a similar sort of thing, and they had the cancer drugs budget. Us and the UK tend to sort of have a sinusoidal curve up and down. Sometimes we're better than them, sometimes they're better than us in the sort of new cancer treatments. But in short answer to your question, no. And that is the kind of discussions that take from 12 to 18 months from a drug gets a license to when it can actually be prescribed.
Okay, there was a lady at the back with her hand. Oh, sorry, gentleman there. Yeah, okay. And we need to leave it at those three people with their hands up. Yeah.
If you have a P53 deletion, ibrutinib is licensed and available and reimbursed in Ireland.
Okay.
If you have relapsed CLL, ibrutinib is licensed, fully reimbursed and available in Ireland, as is idelalisib. If you're intolerant or have relapsed after ibrutinib, venetoclax is licensed and fully reimbursed in Ireland. The difference is ibrutinib and venetoclax are not available frontline for CLL patients in Ireland, and venetoclax is not available frontline for P53 deleted patients in Ireland. As I've probably shown you, there is evidence to say that these drugs are probably better in frontline, and that's not available in Ireland outside the current trial, CLL 13, which is open, and again, when CLL 17 comes to Ireland in about a year's time.
Okay.
Thanks very much.
Patrick is almost out of time, so just two people with their hands up. If we could keep the questions really short so we can...
Probably my answers are too long.
I didn't like to say anything, Patrick. Yeah, sorry, that lady there with her hand up, and then there's another lady, yeah, and unfortunately we'll have to leave it there because Patrick is under real time pressure, I'm afraid.
For ibrutinib, they have follow-up data in sort of long-term follow-up data, and about a third of people stopped it. And out of the third of the people that stopped it, half of them was because it didn't work, and the other half of them is because they couldn't tolerate it. So about a sixth of the people that are on ibrutinib can't tolerate it, which is pretty low. Rituximab in combination with venetoclax and ibrutinib have been studied. It probably has an additional beneficial effect in combination with venetoclax. It's not clear whether it adds anything to ibrutinib.
And a last question there, sorry, yeah.
It does affect your platelets, so you can have easy bruising on it. Mm-hmm. It's not really a reason to stop it if you can put up with it. Okay.
Okay, sorry to people we didn't get to. I'm so sorry, but yes, Patrick is on call today, so we do need to know. Pat, you never answered which hospital's the bit. No, we'll let you away with that. Ladies and gentlemen, we're lucky to have him in our hospital system. We were really lucky to have him here today. Please give a big round of applause to Professor Patrick Thornton.